M. Nagakar sir is director AIIMS Raipur, director and CEO AIIMS Raipur, and he's also having the additional charge of AIIMS Bhopal. Sir is not only a very loved or admired administrator, but also he is a very magnificent and the caring surgeon. So we always give example that even sir has operated a patient 2 years back, maybe as assistant when patients are meeting to us more often, but we may forget the name of the patient, but sir always remember the name of the patient. So that is how we try to imitate him in all the ways we can. But I think that would not be possible in this
Like
lifetime.
this.
But we need his blessing always.
Always.
And we have Dr. Rupa with us. Dr. Rupa is our contemporary from AIIMS Raipur also, and she has keen interest in otology and various ENT surgeries. So we'll start with the sir's initial introduction, and sir would tell us that how why it is so important to have these temporal bone dissections for ENT training. So sir, over to you, sir.
So thank you very much, Dr. Vikas. I'll also like to share and take the slide share here. So are my slides visible, Dr.
Yes,
Vikas?
sir. Yes, sir.
So thank you very much, Dr. Vikas, and your entire team. I can see Dr. Utkal also very active as usual. You've done a wonderful job by organizing this particular AIIMS Bhopal Otology course 2022, and you already had the 5 modules, and today's will be the 6th module, which are obviously precursors for the main workshop which is being held. Congratulations to you and your entire team of faculty members, resident doctors, and support staff. I also welcome Dr. Rupa Mehta, my very valued colleague here. She's an additional professor in ENT head neck surgery. And first, I will be giving a very brief forward and importance of the temporal bone dissection. And then she'll take over and she will speak on, again, introduction to temporal bone dissection, instrumentation, and etiquettes. So I think it's a very important topic for all of us. It's very important to know that we remain lifelong learners. Even the most trained and experienced person also remains a student. And temporal bone dissection is so important at various stages. I'll give an example. Many otologists were highly trained, but when cochlear implant surgery started or skull-base surgery, new techniques came. Everybody had to go back again to the dissection room to learn the new techniques. So I think it's something which is going to be lifelong, and every hospital, wherever there are adequate number of ENT surgeries being done, you should have your own temporal bone dissection facility. Even if it's a teaching hospital, even if it's not a teaching hospital, I think it will be very useful for your own careers as well as for your patients. So we all know that the temporal bone anatomy is very complex. It demands a profound anatomical knowledge. We are lucky that in today's generation, you got computers, 3D simulations. You can view the various angles of the temporal bone. You can understand the anatomy in a much better fashion. But again, nothing better than dissection and seeing it for yourself while you perform temporal bone dissections with proper instrumentation and microscope. We all know that there are some very important structures related to the middle ear, inner ear, facial nerve, eighth nerve. Then we have the relations with the cranial fossa, the middle and posterior. There are very vital structures related to the nervous system, to the vascular system, very important blood vessels. So whether they're otologists, whether they are neurosurgeons, skull-base surgeons, everybody needs to practice on the temporal bone. And we have to avoid surgical mishaps at all cost and to reduce the iatrogenic morbidity and mortality to bring it down to as low as possible. Duckworth has mentioned that an essential way of learning temporal bone anatomy and surgical technique is through repeated dissections of the temporal bone in a cadaver. And this can be done at your clinic, in your hospital, or in the medical college, in the wherever the facilities is available, and the setup should be developed. The workstations should be available, and it's more important that expertise is more important than experience. And how do you gain expertise? You gain expertise by repeatedly doing the same thing. See your seniors operate. You learn from them. You practice the same first on the temporal bone, and then go on to doing live surgery. So this is a sort of a setup, and more details would be told to you by Dr. Rupa Mehta in the upcoming next lecture. The picture down there shows the lab as it exists in AIIMS Raipur, and similar, I think, workstations which are available in many hospitals now, along with good microscopes and other facilities for viewing, so that you can learn better, and the senior teachers can teach the juniors in those particular devices. So we know that traditional methods of surgical education, they were focused on the need of the on the experience in order to gain insight and refine surgical skills. I think that's equally true today also. The more you can do the procedure, the more you're going to understand the depth of it. And similarly, temporal bone surgery also has its own challenges. You have to develop hand-eye coordination, and to learn those fine motor skills, and plus understand the anatomical knowledge under magnified vision. We know that every temporal bone anatomy is different. The degree of pneumatization varies, and that's the reason that I think you have to do more and more, so that there are no surgical surprises or anatomical surprises, because those kinds of malformations are also unexpectedly encountered. So most of the medical institutions, like I mentioned, are using cadaveric dissection as part of their anatomy training. And we also want that the same type of cadaveric dissection should be available for the surgical residents, for example, for otology, skull-base surgery, neurosurgery, and various others. So you have to have a combination of both the lab cadaveric dissection as well as the live surgical experience. And I always want that there are trained and experienced teachers in our country, and they have to play a big role in training the next generation of otologists who will serve our nation. And cadaveric dissections, a very specific feel is the haptic feel, or the haptic feedback sensation. And that's the way when you're actually conducting the dissection, that it will help you the most. So we have various forms of our mental faculties, physical faculties, which are you use when we are in the operation room. And I think all those you can practice in the temporal bone dissection lab also. So as I mentioned, whether there is an over-pneumatization of the mastoid or a low-lying dura, variations in otological anatomy, many a times the facial nerve is in a different position, the ossicles are in a different position, plus the disease itself is going to change the anatomy. So to understand what is the normal anatomy, and only then it is possible to understand the diseased anatomy. So I think cadaveric bone dissections will become very important for all of us, as they have always been. New technology is always coming, and we know that virtual reality models have come up. In many ways, simulators have come up, and they have tried to bring the situation to as close or as real life images as possible. But still, when it comes to the temporal bone, it's been, if you compare the two, it can act as complementary, the VR model, but absolutely no replacement of the temporal bone dissection feeling as of now. So the temporal bone dissection lab will continue. You might have further additions because of the VR, leading to better adaptation of technology. So simulators have been now in used in surgical practice, as in other aspects of medical training. They would play a complementary role, but I would feel that the temporal bone dissection would still remain as mandatory as ever. So, of course, we know that all this has a high cost, but still, I think all these labs are important, and nothing better than saving the life of a patient. So everybody has to practice the temporal bone dissection in the lab. Just to conclude, we know that the bulk of the surgeries being conducted, if we talk of ENT surgeries, are related to otology, almost 50%. And before going on to actually perform live mastoid surgeries, it is best and rather highly recommended that you should do cadaveric dissections under the guidance of a senior, and only then start assisting the live surgeries, and then gradually start doing it step by step. So I think that's been done all over the world, and that's what we should also practice. And again, The anatomy is complex, but if you start understanding the knowledge and gain the knowledge of the three-dimensional anatomy, it's a very fascinating subject, I tell you. The kind of diverse procedures which can be done, it's truly amazing. I mean, it's one skill that only the trained person, and so that's why otology remains the core of the ENT head neck surgeon, and that's something that nobody else can take it away, because it requires that kind of a training which you get during your practice as an ENT surgeon, and your hours which are spent in temporal bone dissection. As far as your actual course now is concerned, there are many temporal bone dissection manuals which are available. There are so many of those available online. So before you actually go on for this course, I would strongly recommend that go through those temporal bone dissection manuals. You'll have a mental picture, three-dimensional, of the temporal bone anatomy. Like for any surgery or medical field of ours, keen observation remains the key. And when, like we do live surgery, we always prefer to go step by step and not miss steps, because every step is vital. So even when you do the dissection, you train yourself like that by going in a step by step manner, identifying the various landmarks. And the more you start exploring it, you're going to enjoy it, and you'll understand how fascinating the subject of temporal bone anatomy is. It starts with the temporal bone dissection lab, and it's going to end over there, because you have to keep practicing it, and it's not going to stop at any stage. So even at a later stage, I would always recommend, whether it's the junior, whether it's the highly trained, everybody should go back and keep understanding this fascinating 3D temporal bone anatomy. So thank you very much, Dr. Vikas and your entire team. And I would now recommend Dr. Rupa. She's got a wonderful lecture coming up. If you've got any questions, Dr. Vikas, or we should proceed, please tell us.
Yes, sir. Thank you, sir. Thank you very much, sir. So, I think, do we have
Thank you so
any
much.
questions? I think we can start with the next one, sir.
Yeah.
Right.
Thank you, sir. Thank you very much.
Thank you so much, sir. It was a nice overview of the entire thing. The students, the participants should, inculcate all these habits for proper temporal bone surgery. I would just share my screen. And before I start, I would just share, sir is so much interested in academics. He's not keeping well yet. He has taken time out. And despite being unwell, he has spared time for all of us and joined us. So we're very grateful, sir.
Thank you so much.
Is the screen visible?
Yes, yes.
Yeah. So we'll proceed with the topic, the temporal bone dissection, instrumentation and etiquettes. Now, as William Harvey has rightly said, I learn anatomy not from books, but from dissections, not from the tenets of philosophers, but from the fabric of nature. So briefly, completely describes the importance of doing temporal bone dissections for learning surgery. As sir has already told in his presentation, temporal bone anatomy has is very complex and has three-dimensional structures running through the bone, and we have to, they are not visible. We have to drill to approach the structure, but we should not unroof, or we should not make them. We should not approach the structure, the soft tissue structure, but maintain a layer of bone over that. So for that you should have a three-dimensional understanding of the anatomy. So for that matter, we have the temporal bone dissections, the cadaveric bone dissections, have a very important role to play, because they are the most authentic, simulations of surgery, as they provide a proper haptic feedback and complete surgical feel you can get when you do a proper temporal bone dissection step by step. This is the pic of the last cochlear implant cadaveric dissection we did in December 2021. This is the temporal bone dissection lab we have in our institute. The dissection lab consists of various temporal bone stations, which include the operating room. Okay, just a second. Okay, I'll just check. I'll just present. Just a second. Now is it changing?
Now please change. This is the first slide. Please change.
Yeah. Now is it going ahead?
No. So what you have to do is that you first have to stop presenting and you have to go to the slideshow itself and then you start presenting.
Okay, fine.
This is how Dr. Uttala.
Just a second. Then how do I go and so when I do slideshow, how do I go back and like go to the companion mode में जाना पड़ेगा, I suppose. Because how do I go back? Okay, just a second, I'll see.
Minimize it and then again maximize it.
Yeah. Sorry for the trouble, but yeah.
मैम आप है ना प्रेजेंट कर दीजिए स्लाइड को, उसके बाद आप गूगल मीट में चले जाइएगा।
Okay, fine.
वहाँ से फिर शेयर कीजिएगा, जो स्लाइड शो की है आपने उसको शेयर कीजिएगा।
उनको करते जाने दो ना, आपको स्टेप बाय स्टेप। मैडम डॉक्टर रूपा, आप ऐसे करते जाओ, लाइव ही इज टेलिंग यू। ओके,
Yes.
आप बोलो उनको।
मैम आप पहले इसको प्रेजेंट कर दीजिए, उसके बाद शेयर कीजिएगा। पहले स्लाइड को प्रेजेंट कर दीजिए, प्रेजेंट मोड में,
स्लाइड शो में ना F5 पे करो, स्लाइड शो पे ले लो पहले।
Yes. When I do in slideshow, but then I have to go to Google Meet, no? So then I have to like minimize and do again, na?
या पहले स्लाइड शो पे चले जाओ।
Yes. How is it seen? It's changing now?
या
Of the temporal bone dissection lab, right?
या
Oh.
सेकंड स्लाइड अब चल रही है, ठीक है।
Now it is moving ahead. I'm just moving just to see whether it moves. Now is it moving? I'm just moving the slides so that so still not moving it.
No, we are on the second
No.
one still.
Oh, then I actually moved 4-5 slides and no, but it's not moving. Like I checked, I moved 4-5 slides and just to check, but it's not moving.
नहीं, उसको वही करना पड़ेगा जो बोला है।
मैम आप है ना, जैसे आपने अभी स्लाइड शो कर दी है, तो आप है ना जैसे शेयर में जाइए, जैसे शेयर करेंगे वैसे उस जो आपने स्लाइड शो की है उसी को सिलेक्ट कीजिएगा, तो आपका स्लाइड मूवमेंट करेगा।
When you press present now, then you will see n number 3, 4, 5, 6. You have to click on the.
Yes, I'm doing the same actually because we conduct classes also on Google, so I'm aware, but somehow it's not happening. I'm just trying again because.
Is it Mac system? Is it Mac?
No, sir. I don't have Mac. I'm working on HP.
Okay. Then it should not be an issue.
मैम ऐसे में भी आप हेलो आप जो स्लाइड उसको पहले स्लाइड से तो स्टॉप कर दीजिए और आप पहले स्लाइड में चले जाइए, वहां से आप उसको स्लाइड शो कर दीजिए पहले। हाँ, तो अल्ट टेप के साथ दीजिएगा, अल्ट बटन के साथ में नहीं, अल्ट बटन के साथ में टेप दबाइएगा। ALT बटन जो है, ये LT जो है विंडो के साइड में, अल्ट और टेप बटन, टेब TAB टेब,
Alt ALT और टैब।
आप वहां से आपको स्क्रीन, हाँ स्क्रीन के पास पहुंच गए होगा। हाँ हाँ, आपने मैम 2 बार दबाइएगा, एक बार अल्ट को दबा के रखिएगा और टेप को 2 बार दबाइए।
इतना कॉम्प्लेक्स तो नहीं है, क्या बता। Yes, Dr. Rupa. Unmute कर लीजिए.
Yes.
Yeah, I think now it was moving. पीछे चले जाएंगे एक बार. Go to the first line.
Yes, sir. Yeah. Yes, sir. Now is it visible and is it audible also?
Rupa slide me. The slides are not moving actually. Can you? Yeah, now it is. Now it is. Yeah.
Yes.
Go to the first slide, please.
Yes, sir. Yes, sir. So we'll be
Okay, it's okay now?
Yes, sir. Now is it moving, sir?
Yes, sir. Yes, sir.
Yes, I think everybody's agreeing.
Fine,
You can
fine.
start, Dr. Rupa, now.
Yes.
Yes, sir. So sir has very nicely elucidated the importance of temporal bone dissection. So this is the pic of the temporal bone dissection lab in our institute. Every temporal bone lab has multiple temporal bone stations, which include operative microscopes, high-speed drills, suction irrigation machines, and standard otologic instruments. Now, temporal bone dissection is important to understand the variations in anatomy, so that when we do surgery in live patients, we can avoid complications and perform the surgery skillfully and with confidence. And when we repeatedly do temporal bone dissections, we understand the anatomy so well that we can tailor make the surgical steps for every different presentation of the disease. So for surgical innovation also, so it is, as sir rightly said, it is not for the beginners or trainees only. Every surgeon, every otologic surgeon, whatever stage of career, at whatever stage he is, regularly performs temporal bone dissection to enhance the skills, to understand the anatomy, which is so variable in each and every patient, so that we can improvise and hone on our skills. So we'll be covering the topic regarding the instrumentation and also the basic concepts which are important for safe temporal bone surgeries, because these important concepts will help us in doing the surgeries more efficiently when we start operating initially on patients. The various instrumentations include the microscope, the drill, the various burrs, the micro instruments, and the temporal bone holder. And along with these, we should also understand the position of the patient and the surgeon's position is very, very important, not only for ergonomic positioning, but also to avoid complications, because you have to have a stable hand so that your instrument, your burr doesn't skip and injure the surrounding structures. Now, surgeon position, as we all know, mastectomy is almost 2-3 hours surgery, and if you perform lateral skull-based surgery, it's even more prolonged. So the surgeon should have a comfortable ergonomic position so that he can continue the surgery with maximum stability and with with more efficiency. So the posture has to be good. The thigh has to be parallel to the floor, shoulders back, neck relaxed with head squared over shoulders. It should not cone in, or there should be no neck or stiffness. And the hand should also be stable and relaxed. So setting up the bone, first we have to identify which side of the bone it is. Okay, identify the landmarks on the lateral and the medial surface, and clear the soft tissue. When you get the bone, it has a lot of soft tissue around it. So you have to clear the soft tissue, identify the site, and then place it in surgical position in the temporal bone holder properly. So that, you see, the most important thing is that you have to perform the temporal bone dissection as if you are doing a surgery on a live patient. Then only we'll be able to understand, and as it was very rightly told in sir's presentation, that step by step identify each and every landmark and perform the dissection as if you're doing a surgery on a patient. So picture in your mind, the sigmoid sinus, the various where the structures will be, so as to define the limits of a dissection. Trim off the remains of the cartilaginous external auditory canal. Fix the bone very properly in this temporal bone holder in the surgical position, and visualize tympanic membrane if present. Now, when we do surgery in live patient, the position is equally important. The head should be rotated to the opposite side. There should be no tilt in the head. However, the head should be flexed so as to ensure that the axis of your surgery and the axis of patient's ear is in a single line. Now, how to set up the microscope. This is again very important, and because the entire surgery depends, like you have to microscopic surgery, you have to perform microscopic surgery. So this makes you, if your microscope is adjusted properly, it makes the surgery go very smoothly. So first of all, you have to adjust the resistance of the joints and the balance of the microscopic head. Choose the correct lamp setting. Check that both the eyes are in focus. Check orientation of the observer arm before you start the surgery. Because once you have focused and the beam splitter in the observer arm changes, then it you have to change it multiple. You have to change your focus again. If you wear glasses, fold eye relief. The black thing which is seen, that is the eye relief that you fold outward to minimize distance between glasses and eyepiece. Adjust distance between two eyepieces and set diopters of both pieces at 0. Both eyepieces at 0. Initially set the magnification to low power and then adjust scope by using focus knob. Once it is done, then you switch, then you move it to high power and adjust the diopters of each individual eyepiece to obtain the sharpest image. And then remember your diopter readings for future use, both the distance and the focus. Now, a few basics of holding the drill and the micro instruments. You have to hold drill like a pen, but you don't have to, wrap over your fingers over the drill shaft, because then it will obscure your view. So your hands and your thumb, your fingers and your thumb should be in such a position that you can have a clear view of the bone you're drilling. At no point you should drill blindly. Then always fulcrum. Whenever you're drilling, your hand, your elbow should rest on the surrounding, patient's face. When your elbow should rest on the table. Okay, so always fulcrum. Never float your hand while drilling, because if most of the surgeries, a few of the surgeries are done in local anesthesia. Suppose the patient moves, then if your hand is stable, you will not injure the structure, and you can very well take out the instrument easily. Rest your wrist or anchor 4th and 5th digits on adjacent structures, bone or the dissecting bowl to stabilize the drill. Again, micro instrument hand position is very, very important, especially so when we're doing endometrial approaches like stapes and all, where we are working through the external auditory canal. If you don't position the fingers properly, like in the picture, it is shown in the lower picture, if the incorrect grasp is there, then it obscures your area, obscures your target area. And so that is how, you have to keep your fingers on the speculum so that it supports also the points of stabilization, and also it doesn't obscure your view. So that is very important. So see, the picture very clearly shows that if your hand is dangling in the air, it is not stable and it is not having points of anchoring points at the elbow and the wrist and the fingers, then it is very difficult to perform the delicate movements, the precise movements which the ear surgery requires. Now, burrs. Drill bits or burrs, as we know, are of two types, basically a diamond and cutting. Cutting can be, multiple flutes are there. So it is defined by the number of flutes it has. And diamond burrs are of various types, like fine, regular, and coarse. Now, how do you select the drill bit? Initially, when you have to do a lot of bone removal, you use cutting burrs. Okay. The lesser the flukes the cutting burr has, the more, the more aggressive it is, the more bone it will cut. Okay, and the more chances of it skipping is there. So we have to be very judicious in selecting the burrs at what stage of surgery, which burr to use. So initial part of the surgery, when you're removing the lateral cortex of the mastoid, then you can use cutting burrs. Then when you reach nearer, when you realize that, okay, now you will be reaching near a vital structure, for example, facial nerve, for example, dural plate, sinus plate, then you should change over to diamond burr. Now, diamond burrs are used when working close to or potentially close to critical neurovascular structures. First thing. Second thing, they cause less soft tissue injury. The flap, suppose a flap gets entangled, diamond burr will not tear it so badly as a cutting burr. And third thing is that hemostasis. Whenever you find a little bleed from the dural plate, you can just take a diamond burr of large size and just drill without using water irrigation. So the bone dust will clog and stop the bleeding. But it is not that diamond burrs are completely safe, because they cause a lot of thermal, they generate a lot of heat. So they can cause thermal injury to facial nerve specifically. So you have to be very careful and use wherever you're using near a critical structure, copious irrigation should be used. Now, regarding size of the drill bit, the basic tenet is that you should use the largest size of the burr, which that space allows. It is not that when you're doing adatus, you will use a 5 mm burr, because then it will drill the surrounding structures, which we don't want. So at whatever area you are, in that specific region, whichever is the largest size burr you can use, that burr you should use. Because first thing, the small burr, no, it will penetrate, will not even realize. So larger burr, because it leads to a larger drilling area, we have more visibility. First thing. Second thing is that the smaller the drill bit used, the more force it has, the more likely the possibility of damage owing to higher pounds per square inch at contact surface of the bit. So this is very important in choosing, deciding which burr to use when. Then use, we have to drill with the side of the burr rather than the tip. Now, typical drill bits used, this is showing the various sizes, for initial saucerization, you will use a larger burr. When you reach the, smaller structures, like when you're near the labyrinth or near the mastoid segment, you use when you're near the additus, you use a smaller burr. Okay, and whenever we reach the vital structures, we change over from cutting burr to diamond burr. So this is, and this diagram below shows the, the direction of the drilling. Whenever we are close to a vital structure, we should drill in a direction parallel to the structure and not perpendicular to it. So that is the basic tenet. Now, adjust your drilling location, force applied, direction, speed, according to the according to the region which is being drilled. And this is also a very important exercise. So drilling, the section helps you in understanding this. So it's an exercise in hand, foot, and eye coordination. You have to, when you have to feel the bone. Okay, and modify your and see also whether you're noticing the change in texture and the sound of the drill. So all these things you have to coordinate and then decide. Okay, now drill stroke should be in one direction instead of back and forth, and long steady stroke should be used. You always have to start the drill before touching the bone. Direction of drill strokes should be the same as in the burr rotation direction. So this prevents the drill from skipping. When drilling in close proximity to vital structures, drill away from them instead of toward them, regardless of which direction the burr is rotating. It is better for drill to skip than to accidentally damage a vital structure. Now, movement of the drill bit should proceed along the axis of the underlying structure being exposed and never perpendicular to it. So structures which should be drilled in parallel fashion are middle fossa dura, then your which is drilled in anterior to posterior direction, sigmoid sinus, which is drilled in superior to inferior direction, digastric ridge, facial nerve, and horizontal semicircular canal. Now, trainees early in the learning process tend to drill perpendicular to structures of interest and also to drill themselves into a hole and not saucerize. So we should make your cavity a funnel and not a tunnel. That is very important, because this will risk neural and vascular injury owing both to the possibility of direct contact and to greater likelihood of localized heating. Now, read the bone. That means whenever we're drilling, we should see, okay, next, how is the bone surface changing? It is not that we're just drilling, in a similar fashion. We have to change our speed, change our, burr and understand, okay, which is the next, anticipate which structure is coming next. So we have to read the bone constantly. So should not drill the bone if the bone cannot be read, if you're not having a direct vision of the bone being drilled. Okay, adjust the microscope and position of the bone to read it en face. Then saucerization allows better bone reading because you have a wider area, you can see the nooks and corners of the cavity, and you can drill under direct visualization. Now, copious suction irrigation is very, very important because, as we said, we have to anticipate the structures before they come. So when you're constantly irrigating and suctioning, you can visualize the prospective structures through bone, which become semi-transparent when adequately hydrated. Then it protects neuroanatomical structures like facial nerve, etc., from thermal injury by acting as a heat sink. And it constantly, the bone dust clogs the drill bit. So it constantly cleans the drill bit, therefore making it more efficient for drilling. A suction tip should be placed wherever you feel that dust and water can be removed effectively. It can also be used to shield vital structure from drill in case the drill accidentally slips whenever drilling. And even suction is used to support whenever you're doing tympanoplasties, to support ossicles. We support the ossicle with the spine suction and then we work on it. Okay. Now, visualizing critical structures through bone, that is again very, very important. That is the exercise we have to learn. That is through the multiple times doing temporal bone dissection. Facial nerve, labyrinth, sigmoid sinus, and carotid artery are encased in bony canals consisting of cortical mantle surrounded by pneumatized bone. Now, thin cortical portion of canal must be preserved and surrounding pneumatic bone must be extirpated. So we should be, we should train ourselves to be able to visualize this cortical shell of prospective structures through ASS while drilling close to them. Now, this learned sense is garnered through repetition and practice. Only then will one be able to detect barely distinguishable changes in color and texture of these bony canals, indicative of appropriate stopping point for drilling, so that we don't cause inadvertent injury to vital structures. Now, how saucerization helps? First, it helps in adequate visualization, okay, so that we don't, like injure any structure inadvertently. And second, also by reducing the cavity size, like once we've done mastoidectomy and all, when this cavity is well saucerized, the soft tissues will sink into it and obliterate it. So that is, saucerization is a very, very important tenet of doing mastoidectomy. Now, mastoid antrum, as we know, is the largest air cell located posterior to suprameatal spine, inferior to the middle fossa dural plate, and anterior to sinodural angle. On its base, we can see the lateral semicircular canal bulge, and it communicates anteriorly with editus, okay, in which the lateral semicircular canal, the short crus of incus, and the facial nerve are there, second genu. Now, because these vital structures are located antero-inferiorly, at times when we are not sure and when the mastoid antrum is contracted, then we should first identify the dural plate and the sinodural angle and proceed from there, from posteriorly to anteriorly. Okay, and opening of mastoid antrum is confirmed with identification of editus, which is located medial and slightly superior. So this is the picture showing how we position, and then we make the first initial cuts to identify a triangle of attack. Okay, and then we keep on drilling the bone, keeping a wide cavity, okay, and extirpating the cortical bone, and we go parallel to the middle fossa dural plate. And this diagram, shows very nicely that we should first identify the middle fossa plate and then the tegment plate and then enter the antrum. Okay. So from the temporal line acting as the landmark, in cases of sclerotic mastoid, when the antrum is contracted, low-lying dura and the high, say forward-lying sigmoid sinus, then it becomes at times you have to ideally even neurosurgical residents, they are trained, and even we people in all cases ideally we should first delineate the middle fossa dural plate, the sigmoid sinus plate, and then approach the antrum. Okay. So this is how the cavity appears. First, when we started drilling, we have various air cells. Then we keep on, extirpating that, and we get the dural plate and the sinus plate, the cortical bone over that. Now, another thing, as we have already discussed, that it has to be the drill direction has to be parallel to the vital structures, and the canal wall. We've all gone through the various last modules in which all these things have been discussed. The cortical mastoidectomy and the MRM, the canal wall down mastoidectomies and all. So when we're doing even cortical mastoidectomy, we have to thin out the posterior canal wall so that it becomes translucent. You can see the tip of your instrument through the canal wall, because that again helps in wider exposure. Now, anatomy and its variations, each temporal bone is different, and therefore that is the beauty and that is the difficulty both. So low-lying dura, say forward-lying sigmoid sinus, very, very commonly encountered. Okay, because most of our CSOMs have long-standing, history, long-standing disease, and all the, mastoid cortices are sclerotic and contracted. Okay, corner septum, again a very important, variation which is seen, and though it is in textbook it is said it is not that common, but routinely we see that it is very, very commonly present in many of the patients. Okay, so these diagrams illustrate the corner septum, the contracted mastoid, and the sclerotic mastoid. So in sclerotic mastoid, you have to really drill a lot of bone to reach the antrum, because there are no air cells adjacent, superficial to the antrum. Now, what happens if the low-lying dura is there? Then what you can, at times you can reach through the dural plate. That is of no consequence. If you reach the dural plate, you have to recognize that is important. You should not cause injury to the dura, because then the CSF leak will happen, and then it is problematic. You have to repair it, and unnecessarily you are exposing the patient to the infection. So dural plate breach is of no, it is not of that importance. You have to recognize it and stop at that point, and try to change your trajectory of drilling. Then sigmoid sinus, whenever at times you have very forward-lying sigmoid sinus, and then you can breach the sigmoid sinus plate and the sigmoid sinus, leading to bleeding. Then for which you have to manage by packing, surgical packing, and intraliminal, extraliminal at times. Now, corner septum, again very, very important, and for initial trainees, it is very, very important to recognize this anomaly. Corner septum, as we all know, is an extension of the petrosquamous suture superiorly and tympanosquamous suture inferiorly. It forms lateral wall of it forms lateral wall of antrum and separates mastoid cortex cells from petrous cells and antrum. So if a large hair cell has been opened and no aditis identified, you cannot pass your ball probe to the aditis. Then you should think that the possibility of corner septum might be there, and then you have to explore it. You have to drill deeper to open the medial compartment. Now, this has already been covered in the previous lectures. Must have been already covered, but this is just to make you understand that what they say. What is the correct way of doing is that you have to define your superior limit. Very essential, because then even in contracted mastoid antrums, you won't injure any important structure. So that is very important. So superior dissection should be started 1 centimeter above the temporal line. You define your middle fossa plate, go medially till you reach the tegmen, and then you go towards the sinus plate, define the sinodural angle from medial to lateral, and then approach the antrum. So this technique is especially useful when there is a low or sagging tegmen on a very dense corner septum. Now, posterior dissection, again, you have to identify a posterior border, that is the sigmoid sinus, which runs up posterolateral to anteromedial cords. And you have to keep a thin bone over the sinus and skeletonize it. And the distance between the sigmoid sinus and the anterior structures, which are like posterior semicircular canal and the descending part of facial nerve, that is very variable. So you have to understand this, especially in cases of forward lying sigmoid sinus. So various dissection exercises are there, and they are designed to mirror standard ear surgery techniques. And apart from the standard ear surgery techniques, you can do a lot more exercises to understand the anatomy. So it depends on the time, and I must congratulate Dr. Vikas sir, because he has very nicely designed, so that you can understand, digest, sink, the procedure can sink in, you can read more about a single procedure, and then when you go through the do the temporal bone dissection, you are very well, you have understood, you have read well, and you're very well prepared to do the temporal bone dissection exercises. So the list of exercises is exhaustive, right from canaloplasty, staphydotomy, canal wall up and canal wall down mastoidectomy, posterior tympanotomy, cochlea, inside out mastoidectomy, facial nerve decompression, then your labyrinthectomy, endolymphatic sac surgery, approach to internal auditory canal, which is like translabyrinthine or transtemporal. So these are the various exercises you can do. So with this, I end my presentation with special thanks to our director, sir, Professor Dr. Nitin M. Nagarkar, sir, Dr. Vikas Gupta and AIIMS Bhopal team, and all the participants for which we have taken all this effort, and they should really endeavor to become good otologists. Thank you so much.
Thank you very much, Dr. Rupa. So
thank you, sir.
I think our soon-to-be colleagues who will be here with us next week, most of you have understood that what are the basic tenets or what are the basic etiquettes of the temporal bone dissection, because temporal bone dissection is nothing but actually it is a kind of simulation of the ear surgery to what you perform. So what we always as the ENT surgeons, we discuss among ourselves that there are few surgeries in ENT which are actually more of art than the medical science only, and otology is one of them. And it is something which more and more you read, more and more you do, and more your patients you follow, you start loving it. Because what initially happens, like when I was resident in my house job, AIIMS had this thing that for initial 6 months you would be there in the ward. So, and then you start going to the OTs, and then you start watering the mastoids who other people are drilling. And then for initial like 2-3 months, I was, though we always had these microscopes where there is a stereo observer tube, so we would be seeing. But for initial 2-3 months, it was like, oh, I don't know what they are drilling and what they are achieving by drilling bone and bone and bone. And then you start reading books. So what I found it is that initially I would go to and see these mostly the Sambo or the Scott Brown, and it didn't really help me. Many of you would really be helped with these standard textbooks like Cummings or Shambo, or but the book which really helped me was toss. So when the day I started seeing the toss, everything started getting into the plane, and I started actually understanding it and loving it. That yes, now I understand that why they are drilling here, why they are drilling there. So there are few differences which obviously when you all will be there, that what are the differences when you are working on a temporal bone or on a cadaver, and when you are working on when you are doing a live surgery. So most important them being is that the flexibility of the rotation of head which you get with the patient when he is under GA or under local anesthesia. So that is not there. What we have tried is actually to actually have you the feel of the soft tissue, also the soft tissue work. So we have arranged for the cadaver itself than the bones, and also to make you understand that how are the other structures associated, or how are the other structures placed. Because what we have felt, like I also felt that when you are giving a temporal bone alone, many times you actually start losing the overall awareness that where was my temporal bone, where would be the zygomatic arch, where would be the, so we are having the cadavers where you will be working. We have tried to arrange the best microscopes. So we'll be having size microscope, we'll be having good drills. But whatever said and done, it is always your interest, it is always your inquisitiveness, it is always your uh, knowledge with which you are coming, it is always your intention with which you are coming. So I would request all of you to please come with an intention to learn more and more, and try to whatever doubts you are having when you are like once these modules are finished, you are sitting at your clinic, you are sitting at your OPD, and you just think, okay, oh, I should have asked this thing. You start writing those things and you come with all those questions, and we'll be happy to answer all those questions. We might also not be knowing uh, the answers to few of those questions, but we'll try our best to solve all your queries. And we are looking forward to this event as a lifelong relationship where we can always do the hand holding to the people who are really uh, who really want to excel further, especially into the teaching and training, the people who are coming from the teaching training institutes, and for everyone obviously. So if you have any queries, you may ask, and rest we all have a group where you can always ask those things, anything, anything. Sir is with us or right?
Listening to everything very, very carefully. And Dr. has given very nice tips. And I think you also, with your immense experience, you explained very well to the participants. So I think we can wait if they have any responses, or they can mail those. And of course, the participants would be coming up over there. And
Yes,
they can
sir.
come with their questions for the two-day workshop. Excellent job done.
Yes. So should we conclude, sir?
Yeah, sure.
Thank you.
Thank you, everyone. Thank you, sir.
Thank you, Dr. Upa. Thank you, sir.
Thank
Thank you, everyone. Thank you.
you. Thank you.
Thank you, sir.